let's deepen into defining what is trauma. I actually want to start, though, with this particular quote because it's very meaningful for me, especially from a resilience-informed approach to care, which I want to weave throughout this whole program, even this segment, which is really honing in on where our trauma symptoms might live. But this particular perspective that health is not defined by the absence of disease. Rather, it is recognized by the presence of well-being. And that's from the World Health Organization, and it's up on their website today. And it really touches me because I think so often we come in with this attempt to reduce symptomology, and of course to some degree we want that, but it's not just about getting someone into the state of being normal. Well, what is normal anyway? But actually what we really want is to enhance a sense of joy or freedom or lightness, capacity. And so even as we look at what is trauma and really going towards relieving symptoms, we also are always going to be helping our people turn towards their strengths and that which enhances well-being all the way through the entire treatment process, even from day one. So what is trauma? This is any event that overwhelms the ordinary human adaptations to life. The event leaves us powerless or helpless, with losses of control, dignity, connection, sense of belonging or meaning. And this comes from Judith Herman, Trauma and Recovery. Now, what's so key about this is this concept of overwhelms the ordinary human adaptations to life. So if we go back to our definition of resilience, that is about our ability to adapt or recover from adverse life experiences. And when we look at trauma, it's not so much about the event, but as Gabor Maté says, it's about what happens within the individual in response to the event. And it's really about whether it's overwhelming our coping capacities. I think of it as kind of an economics process or equation in a sense, right? How much are we, kind of able to cope? How much reserves, how much capacity is within us to cope with any given stress? And the more that those stresses occur, when we don't have those coping mechanisms, whether they're inside of us or in our relationships and outside of us, the harder the hit, the more impact that event will have on our psyche, whether it's mentally, emotional processing, our social functioning, and so on and so forth. And I also want to really highlight the second element of this quote, that the event leaves us powerless or helpless. Those losses of control, dignity, connection, and so forth. And the experience of that loss of self-efficacy, that no matter what I do, I, A, can't stop what's happening to me, and B, don't know how to take care of myself in the face of it. I don't know how to help myself cope better with that. And that is very much why this work is relational, because it's not the fault of the individual that trauma begins to land in body and mind and so forth. It's really about our access to resources. And the most important of those resources is relational connection and the ability to feel that we're not alone in our suffering, which in itself is a profound alleviation of that suffering. Now let's define some more specifics here about what is traumatic stress and different kinds of traumatic stress. And the first of these definitions is what we'll refer to as acute trauma. This is a recent traumatic event, and something in the last 4 weeks, right? That kind of timeline. And perhaps the most important thing I want to say about acute traumatization is that it's normal, right? When we feel discomfort emotionally, mentally overwhelmed, somatic symptoms in response to a shocking and unexpected and frightening event, all of those mental, emotional, somatic experiences are expected, right? If you don't feel a certain amount of discomfort in relationship to something that's really scary, we might actually be more concerned. So the ICD-11, which is the International Coding of Diagnoses from the World Health Organization, they took acute traumatic stress and they moved it out of the mental disorder section into the factors influencing health in order to depathologize emotional distress after trauma exposure. So, if you have someone coming in because they've experienced something in their world, this world that we share that feels really shocking and overwhelming, and they feel irritable, agitated, angry, afraid, panicky, or sad, our job is to say, of course you feel that way. Let's hold this together. If they feel numb, disconnected, it's also a way of self-protecting in the face of something overwhelming. Or maybe shakiness, nausea, and dizziness. And that our work is to help move that through together. Right? Sometimes when I have had people that have come in after bearing witness to a shooting or bearing witness to, or they lost their house in the fire, right? Like these really acute events, when they come in, they're literally shaking. And what we want to honor is let that happen. Don't try and shut that down. That is the body's wisdom, letting something sequence through, letting something move through. And we're going to talk a whole lot more about somatic psychology and how we might facilitate it. But, when I think about stories of people who have ended up in the emergency room after trauma, and people are trying to help them calm down, rather than actually help them ride through the wave of the discomfort and the distress and say, I've got you. You're going to be okay. Let yourself feel it. It will subside. Sometimes that's really the message that we need to hear. You're not afraid of my distress. That helps me be less afraid of my distress, and therefore I can trust the process. Now, sometimes we do want to bring in some grounding or some supportive, helpful resources that help an individual or ourselves feel a little bit more capable in the moment, because it can feel a bit overwhelming. But the most important thing when we are offering a resource, such as grounding, like what we started with in our experiential in this module, is that we want to ensure that we are also simultaneously inviting or letting our people know that their distress is welcome in the room. Because sometimes we inadvertently communicate to a client, you calm down, you get grounded, you get resourced because that distress is too much for me too. And we end up recapitulating a wound. So a lot of what we do as clinicians is build our own affect tolerance so that we can help our clients build their affect tolerance. When we've experienced acute traumatic stress, we really want to have access to resources. It's preventative for the development of post-traumatic stress. And when we look at PTSD, I often think of that word disorder as kind of a secondary element, that post-traumatic stress in itself is difficult, it's challenging, it can lead us to feel overwhelmed, or it can lead us to shut down in our ability to process the event. But we also want to depathologize it, which is why I often put that disorder in a parentheses or in a quotation marks. And what we're looking at with post-traumatic stress is that the physiological and psychological effects of the acute trauma stick around. They persist. Typically, when we're shifting over to a PTSD diagnosis, we're looking at those symptoms persisting beyond 4 weeks. And that we see 3 categories of symptoms. The first of these is re-experiencing, which means that the individual is more likely to experience intrusive memories, intrusive sensations, maybe nightmares or flashbacks of the event. And then there's also avoidance symptoms, where the individual might begin to avoid going to places or being around people that are reminders of the traumatic event. And then lastly, there's often a category of symptoms, the experience of this heightened sense of threat or arousal, or what we refer to as hypervigilance, where the senses are keyed into the potential threats in my environment, whether that's jumping in relationship to a loud sound, or if it was interpersonal violence, being very vigilant to the body language of other people. So watching for those kinds of symptoms or reports from our clients can help us really fine-tune when that traumatic stress is sticking around. And then it's also really important to differentiate that there's another subtype of PTSD, because in the classic PTSD, what we're looking at are typically hyperarousal symptoms. Anxiety, panic, high awareness of the body, overwhelming emotions and sensations. But the work of Dr. Ruth Lanius has really illuminated a second subtype of PTSD, which she refers to as the dissociative subtype. And this tends to occur with high severity traumatic exposure. In this case, there is more of a predominance of derealization and depersonalization. So the world doesn't feel real, my body doesn't feel real. And what facilitates this is this lack of interoceptive feedback that leads one to feel disconnected from the body. The body doesn't feel like your own. So interoception is that internal sensing of your own body. And what begins to happen with the dissociative subtype is that instead of the midbrain being highly activated, our limbic brain, which houses the amygdala and other emotion processing centers, in classic PTSD, those are real lit up. In the dissociative subtype, those are dimmed down. In classic PTSD, we tend to see less activation in the prefrontal cortex. But in the dissociative subtype, we see the opposite pattern. The prefrontal cortex is highly active. And there's a reciprocal inhibition between these two areas of the brain. So the more that the upper brain centers are highly active, intellectual defense, think about that, right? The more that I think, the less I have to feel. And it dims down or dials down our sensory awareness of sensation and emotion. Now, if we are walking around the world like this much of the time, we start to feel disconnected. The world around us doesn't seem quite as real. You might feel like you're in a daze or a fog that's not medication induced. And it's harder to remember details about traumatic events. So what I often think of here in our practice hint is that recognizing the presence of PTSD requires becoming curious enough to listen to what is not being said. Because when someone is in this dissociative subtype and they're having a harder time verbalizing or talking about or even remembering the event, what we're really then paying attention to are the symptoms. And sometimes those symptoms don't look like classic trauma, right? They look like someone who's really in their head, right? Can talk about things but has a hard time feeling. Or maybe they're more hypo-aroused. They're in more of what we would think of as depression or even major depressive symptoms. But if we don't look through that trauma-informed inquiry to try and understand them, the individual in the context of their history, we might just say that person's depressed without understanding that those symptoms of depression might actually be rooted or have an etiology within trauma, especially childhood trauma.